I thought I really nailed that first take too. So. Good afternoon, everybody, and welcome to the weekly seminar here. We have Ramos joining us from across the bay. He's assistant professor at UC Berkeley in psychology, and he does really great work in a number of ways that I think are important, not only to the center here, but also to the world. The first is he's thinking about health inequities across a number of different communities, and I think that's absolutely crucial as we think about how technology is changing the way people get access to mental health. But he's also really right at the state of the art on understanding how digital interventions for mental health play a role in supporting people and the potential that they have, as well as some of the pitfalls. So please join me in welcoming Ramos.
Did I mess it up already? Let's see. It's working. Thank you so much for having me. It's an honor. Today, I want to give you an overview of some of the work that I've been doing. I want to challenge some assumptions that we see in the literature, and I would love to have more of a conversation with you and see what you think about the role that digital interventions can play in advancing mental health equity. Just a disclosure, most of the talk will be focusing on racially and ethnically minoritized individuals, but the same lessons apply to other marginalized groups here in the United States, okay? And I will be happy to discuss how that work and some of the findings apply to other groups if you're interested. Let's just start by getting an overview of the issue that we have at hand. In the United States, 1 out of 4 people at any point in their lives are gonna meet criteria for some type of mental health disorder. So 1 out of 4, even right now in this room, are very likely to meet criteria for some type of anxiety disorder, depressive disorder, or other disorders. So even if you are not personally affected, you for sure know someone who is. With that in mind, in the United States, if you're a racially and ethnically minoritized individual, you are less likely to access services despite having similar prevalence rates or even higher prevalence rate compared to white individuals. You are also less likely, let's say, that you receive services. They tend to be of lesser quality, meaning that you're gonna receive fewer sessions. Sometimes you're not gonna receive what we call evidence-based treatments, meaning treatments that we know based on scientific findings that they work, and you are more likely to leave services prematurely. Okay, so as you can see, at any stage of the mental health care path, there are inequities for racially and ethnically minoritized individuals. With that in mind, a lot of us saw potential in digital mental health interventions to address some of these inequities. How? By increasing reach, maybe reaching people who wouldn't receive services otherwise. Providing evidence-based treatments. Once again, interventions that we know that work with 100% fidelity because they are pre-recorded in these digital interventions. And also providing things that maybe fit better with people's lives. Moving beyond that model of once a week for 15 minutes with homework in between weeks for 12 weeks at the very least. Maybe we can offer something that looks different, but it still moves the needle for people. However, I will say that whether digital mental health interventions are achieving this goal is to be determined. It's still an empirical question. And given that, my goal for today is to share with you my understanding of the state of the literature, the state of the science in digital mental health interventions. I would love to hear your thoughts about some of the findings because some of them run counterintuitive to some of the things that we believe in the field, at least in clinical psychology. And later, I want to show you a way in which I have applied some of those lessons in my own work, trying to advance digital mental health with an equity lens, okay? So let me just walk you through the state of the science in digital mental health interventions. Once again, there's so much in this field. I want to emphasize that I will be covering mostly the literature from a diversity, equity, and inclusion lens, but also an implementation science framework. For those of you who might not be familiar with the RE-AIM, this is a model that we use in implementation science to understand how evidence-based interventions in any setting can be sustainable in the long term. In other words, things that we develop in universities, how can we apply them, for example, in community settings? Okay. With that in mind, part of my career, I have spent trying to understand, getting a good sense of the literature out there. Pre-pandemic times, before everyone was so excited about digital mental health interventions, I wanted to know if this would work for racial and ethnically minoritized individuals, how well we cover issues of diversity, equity, and inclusion, the state of the science for specific disorders, how we can actually integrate people from the community to develop better interventions, etc. So I won't be able to cover everything, but I just wanted to share with you where this data come from. Okay, let's start talking about diversity, equity, and inclusion. There are so many different definitions, but I will be using this specifically when it comes to digital mental health. We were interested in getting a sense of how well the frameworks that we use to evaluate digital interventions capture issues of diversity, equity, and inclusion in terms of access. In other words, things that might get in the way for people accessing those interventions in the first place. Think of internet connectivity, how much data do you need? For example, if you're not connected to Wi-Fi, how much do you have to pay for that? The system requirements, do you need a really fancy device, or can you use something that, like closer to a flip phone type of thing? We also were interested in terms of the content of the intervention itself. Is it available in other languages? What is the level of literacy that you need to actually understand the text? And that also includes digital literacy as well. Can you tweak the intervention based on disability or specific needs? And finally, if some of the content was reflective of populations beyond the majority white in the United States. So these are the results. It will look kind of like, okay, maybe we are not doing terrible. 60% of the frameworks that we use in the field capture some type of diversity, equity, and inclusion criteria. However, when we start like breaking that apart, most of them, 97% of them, just have one consideration of diversity, equity, and inclusion. Okay? And the most common when it comes to access, for example, is cost. People are concerned about whether people can pay for these specific services. Not surprising. When it comes to content, for example, the most common one is related to disability, to specific needs, mostly auditory and visual. We don't do terrible when it comes to that. But now it's when things get like really sad, because, for example, none of the frameworks that we review assess whether you were able to change some of the content based on your identity. Or, for example, just one framework, if there was diverse visual representations. Think of the avatars, the people who are actually depicted in the intervention. If there's like a psychoeducational video teaching mindfulness, is the client depicted and the therapist depicted just white, or are there other identities? So my takeaway is that we are doing really poorly when it comes to thinking about issues of diversity, equity, and inclusion in how we evaluate digital interventions. That's that piece. Now I would like to give you a sense of who we are actually reaching with these interventions. The reason why I got so excited about the potential of digital interventions was to reach communities that I know wouldn't receive any other services otherwise. Are we actually achieving that with digital interventions? Well, no. Unfortunately, that's not the case. We are reaching mostly white samples, like in what we see in actually traditional face-to-face therapy research, mostly female, English-speaking, and middle class by US standards, because middle class in the United States has a very different flavor and level of wealth compared to middle class in other countries. Race and ethnicity of participants in these trials are rarely reported, and that still blows my mind, the fact that we don't have specific demographics of the samples that are included in this type of research, and other important demographics are also ignored. SES, tech literacy, stigma, other marginalized identities. Often, if you see that people report race and ethnicity, we don't know if maybe members of the LGBTQ plus community are actually represented in samples. We just do a really bad job understanding who we are reaching with these samples. So, in other words, what we are doing is that we are recruiting ideal samples under ideal circumstances. Same individuals, I will argue, same individuals that are more likely to actually receive traditional mental health services in the first place. So we are not truly increasing reach in that sense. It starts feeling bleak, right? And it just gets worse. So now when it comes to adoption, the idea that like maybe something is available doesn't mean that actually people are gonna access it and adopt it in their everyday lives. And that's why the adoption metric is important. When it comes to RCTs, when we know that actually people receive all the support in the world, they are paid to participate, often receive check-ins from study staff, even then, 50% of people never access the digital interventions in the first place. So imagine you get this NIH grant, an R1, you have a couple $1 million, and you're super excited and give a digital interventions that you know or you think that is gonna work. From the get-go, you're gonna lose 50% of your sample because they will never access the digital intervention. Now, in the real world, it's even worse. When we see how people use these digital tools in the wild, almost 80% of people never access the app. They get it, but they don't create a profile. They don't even use it once. 80% of them, okay? And if we were to extrapolate, and this is still an empirical question, I want to clarify that from my findings, but if we were to extrapolate from what we see from traditional services, we will expect that racially and ethnically minoritized individuals are going to experience even more barriers to engage with these tools. They just have more on their plates, they are exposed to chronic stressors, significant competing demands, they have schedules that they don't be the 9 to 5 that maybe you see with other populations, and they might be more likely to have low literacy, digital and regular literacy. However, this is rarely tested in the literature. We don't really know how many people we reach, from what groups, what is the rate of from screening to actually recruitment. We don't know what actually successful recruitment strategies look like. What is the best way to reach these populations? We don't have a good sense just based on the literature. Maintenance, this idea, okay, let's imagine that actually you reach the population, they created a profile, downloaded the app. Now, are they using it long enough that they actually are gonna be able to benefit in terms of mental health outcomes? Well, in RCTs, once again, keep in mind, in RCTs, we give them a lot of supports. This is as good as it gets. And even then, up to 75% of people don't complete those RCTs. Something to keep in mind, I know that right now AI is something really hot. A lot of people are interested in that. When it comes to RCTs using AI-powered tools, it seems that engagement is much better. It's like the attrition is around 20%, which I think really contrasts with like the 75% that we see in other tools. Now, in the real world, after 2 weeks, just 2 weeks, only 4% of people continue using these tools. 4%, yeah, 4%. So we lose 96% of people within 2 weeks. And once again, if we extrapolate, we can think that maybe marginalized groups are gonna have more barriers to stay engaged. We need to even understand a more fundamental question related to engagement and maintenance in these tools. We don't really understand what optimal dosage means in digital interventions. Do people need to meditate every day? Is it enough if actually someone completes one CBT course once a year? That's still to be determined. And I have argued that this is a big issue because maybe depending on the specific evidence-based treatment that you are using, the dosage is gonna vary. You can think of some digital interventions that actually are gonna work more like vitamins, something that you have to use consistently in very small dosages. Or maybe it's like a painkiller, something that is maybe a little bit more acute, but you use it for longer, and once those symptoms clear out, you're fine. And in other cases, maybe like a whole CBT course, it's more like antibiotics. You have a specific dosage for maybe 3 weeks, and once your symptoms clear out, you stop using it. So once again, we don't even have a lot of clarity about what optimal dosage should look like in this field. And we make the assumption that that more is better. And that's not necessarily the case. Actually, there's a concept that I really like from this literature about happy abandonment. Some people that we might consider as dropouts might actually leave because they got what they needed, and they are just like, peace out. I learned the skill, I'm fine. We are terrible at capturing that, for example. Probably this is like the only bright finding from this, from my review of the literature. When it comes to effectiveness, digital mental health interventions work. We can consider them evidence-based. In some cases, they are just as effective as traditional face-to-face therapy. This is like seeing a therapist once a week, 50 minutes a week for 8 weeks or 12 weeks with homework in between. Digital interventions can be just as effective as that. However, they have rarely been tested with racially and ethnically minoritized individuals. So given that, many people in the field are concerned, and they argue that actually digital interventions are not evidence-based for racially and ethnically minoritized individuals. They also argue that without careful cultural adaptation, these interventions will fail. I don't agree with that perspective. I will argue that actually absence of evidence is not evidence of absence. I think the issue is that we are not reaching these individuals, recruiting them in our trials, so we can extrapolate that it work for them. In fact, in my own work, we have seen that when these trials include racially and ethnically minoritized individuals, they benefit just as much as members from the majority group. So the issue seems to be more related to reach. And when you have compared, like, there are very few instances in which culturally adapted versus not culturally adapted are compared, but when that happens, more often than not, they fail to outperform the original protocol. In other words, we spend a lot of money, resources, and time creating a new digital intervention that is better than the original one. I guess that this is the finding that is the most controversial from my work, and I don't find it super controversial, but I would love to hear your thoughts. And especially because this is a well-documented pattern in traditional face-to-face therapy. We know from decades of research in clinical psychology, I'm a clinical psychologist by training, that that's the same pattern in mental health. Culturally adapted protocols don't outperform non-culturally adapted protocols. And I will just argue, and one of my concerns is that this idea of having to develop a specific, group-specific digital interventions will never be sustainable. So we need a mindfulness app for Black individuals, a mindfulness app for Latino individuals, a mindfulness app for Asian. I don't think that we will ever have enough interventions. I just don't think that that's sustainable. And even, let's humor me for a second. Let's imagine that by culturally adapting, these interventions are a little bit more effective. Is it still worth like all the time and resources that we're pouring? Let's say that effect size of a culturally adapted app is 1.2, and the original protocol was 1.0. That 0.2, is it worth spending 10 years developing the app, conducting several RCTs? I'm not convinced that that's the case. So with that in mind, what are some takeaways from my understanding of the literature? When it comes to DEI, we do really poorly in the field. I'm of the idea that when you design for the most vulnerable, everyone benefits, and paying attention to context and specific needs of these populations are gonna be key if digital interventions are actually to fulfill their promise to advance mental health equity in this country. And there are methods that we have been using for decades to do this type of work. Community-based research approaches, human-centered design, in which you actually incorporate the voices of potential users and community members. Instead of assuming that we know better, we ask them what they need, and we package it in a way that actually is gonna fit in with their lives. When it comes to implementation, it's really poor. The issues are reach, uptake, and engagement. I was talking to Sonny right before the talk, and she was asking me about like where actually we should pour money and resources. Probably is in the most boring area of digital mental health, which is actually just policy, not even like designing new things. Like if you really want to change this, it needs to be about how we implement these tools, creating the incentives for these tools to be sustainable in a mental health system that it's very unique. And my takeaway is that actually, even then, digital interventions are effective for these populations. The issue is not reaching them. If when we reach them, they can truly benefit from these interventions. And I argue that all these concerns about cultural adaptation and design of new culturally adapted digital interventions are well-intentioned, but unfounded. Come from a misunderstanding that they don't work when we don't have data to support that notion. Is culturally adapting really worth it? To me, we are just reinventing the wheel. We are doing something that, again, we have done for over 2 decades in clinical psychology, and we already know what the outcome is going to be. They rarely outperform the original protocols. Okay, at this point, I've been criticizing the literature and kind of like I know better. Maybe that's not even the case. Let me just give you an example of how I have applied some of these lessons in my own work. I don't think that this is the only way, but I have tried to apply some of the things that I have learned from the literature to try to design more equitable digital mental health programs. And I say programs because sometimes it's not even the intervention itself. It's the packaging and the implementation piece, all those aspects. I think technology is just one piece among the whole ecosystem that we actually need to take into account. So for that, I will be presenting some data from an RCT in which we use digital mental health intervention for racially and ethnically minoritized individuals who experience significant levels of discrimination here in the United States. This work comes from, it was my dissertation when I was a doctoral student. We pre-registered this protocol that in principle gives you acceptance for some of your articles. And even then, you will be surprised about all the pushback that I've been receiving with some of this literature. So I would love to hear your thoughts about that. Human memory for a second. I know no one wants to remember 2020. I know 2020 sucked. We can all agree on that, maybe? With that in mind, though, 2020, I think it's important for us to go back because this was the context in which this specific intervention happened. There was a political rhetoric that actually made discourse against some racial and ethnically minoritized individuals common, which also was translated into more instances of discrimination in the United States. And this is just data, not opinions. I'm just presenting what we have seen in the literature. We also had the COVID pandemic, and certain groups were blamed for the health crisis that we were facing, and that also translated into more instances of discrimination against some specific groups. By the same token, we also had instances of police brutality against some racial and ethnically minoritized groups, and also well documented that at population level, having exposure to those instances translated into poor mental health outcomes for those groups. With that in mind, I was thinking, what is the role that digital mental health can play in this specific historical moment when we are all locked down, people cannot access services, but there's a need for people to cope with some stressors related to race in the United States. So I'm gonna use the same re-aim framework. I'm gonna tell you how I actually try to improve reach, I try to improve adoption, maintenance, and so you can compare about like what I presented to you before and what I try to do and how I try to address some of those issues. The first thing is that we offer a digital mental health that it was specifically targeting the needs of a racially and ethnically minoritized population of the United States. Often there are like generic programs that actually don't try to target these groups. And one of the things that, because we had contact with every single participant here, more often than not, they will say like, thank you so much for designing something that is for us. So they really appreciated that it was for them. We were really intentional about collecting demographic data that was relevant because we wanted to understand who we were reaching, enrolling, and retaining. But also, if you start thinking about later, like further analysis, having those demographic variables will allow us to start testing moderators of treatment outcomes. So for whom these interventions are especially effective, who actually are not benefiting as much, and then maybe we can actually make them even better. We diversify our recruitment strategies. So once again, with this idea of trying to go beyond like the ideal participants under the ideal circumstances, we went out in the community. We have been working with the community for years, and we have partnerships throughout California, some of them in rural communities, low-income communities, mostly Spanish-speaking communities, and we leverage those community partnerships to try to reach members of the community. We also try to diversify social media channels, Facebook, WhatsApp, that actually is a big deal in many racially and ethnically minoritized populations. I'll tell you what actually was effective in a second and what was such a waste of our time and resources. The recruitment materials specifically talk about the needs of racially and ethnically minoritized individuals. It sounds like a dog, it looks like a dog, it is a dog, so we were talking about that. And unfortunately, you cannot see it, but actually in the background, the only individual depicted in the recruitment materials is a person of color. So once again, just trying to reach people that they actually feel represented in this intervention, that these interventions were for them. And we use a smartphone-based digital mental health intervention. Why? Because the digital device still exists. Yeah, it's shrinking year by year. However, most people of color still have a smartphone at home, and they tend to be more smartphone dependent to access the internet. So instead of like when I was trying to decide what intervention we were use, we talked to a couple of companies, and we'll talk about like why we went with a commercially available digital intervention. And there was some interventions that were beautiful, gorgeous, with virtual reality, amazing headsets, kind of achieving everything that we wanted. But I knew that that will never fly with the community that I wanted to work. Like, if I have to buy 250 Oculus sets, it's just not gonna happen. This is not gonna be sustainable long-term in the communities that I wanna work with. On the other hand, maybe a smartphone-based intervention is gonna already leverage technologies that they have available at home. Now, let's talk about adoption and maintenance. So you know that most people never download the app. If you are gonna use an app, they are not gonna create a profile. They are not gonna use it for the first time. So what can we do to actually to solve that issue? And this goes to some of the other things that we were talking, Sonia, a second ago before the talk. The fact that maybe it's not thinking whether if it's technology or humans. What if we combine both? And we leverage the affordances of technology and the affordances of the human contact. In other words, let's make sure that we leverage what technology does well and what humans do well. In this particular case, we had a very brief onboarding procedure, 30 minutes over the phone. Remember, this was still during the lockdown, so we weren't able to interact with people. But over the phone, we helped them download the app, install the app, and learn how to use it. Not rocket science, very simple. And even though you will see that the sample was mostly young and pretty tech savvy, you will be surprised about how many tech glitches and hiccups we had to deal with. And sometimes we make the assumption if people are really tech savvy, they will be able to solve that. What we have found in our is if there's any hiccup for really people that are really tech savvy, they just say screw it, I'm gonna do something else. We also use motivational strategies that we use in traditional face-to-face therapy to keep people engaged, to keep people motivated, to help them generate their own strategies, because we know that they have a life. This is not the only thing that they have on their plates. When you enroll them in their study, they still have jobs, they have families, they are doing other things. So how can we motivate them to keep them engaged long enough so they can benefit from the intervention? And we also provide psychoeducation, information about why we thought that this specific digital intervention was gonna help them, and why if they had any issues or any concerns about the cultural fit of the intervention. Keep in mind, the entire sample was racially and ethnically minoritized. Talking about culture was, I will say, and again, unfortunately, we didn't collect this data, but maybe for 50% of participants, was relevant to talk about this, but for 50% of them wasn't. And sometimes they were even taken aback. Why are you asking me about this? I just want to use the intervention. So again, I think that speaks to the fact that there's no one-size-fits-all when it comes to talking about culture with these groups. They were also able to use personalized notification. We send them 3 automated text messages, nothing fancy, nothing adaptive, morning, night, and during the middle of the day. That maps onto the peaks when people tend to use these digital interventions according to real-world usage data. People hated the text messages. They just truly hated them, but you will see the engagement outcomes. So we can talk about that. If it's okay maybe to have participants who are a little bit irritated but super engaged. We kept track of the success of recruitment strategies. Again, people are enrolling through social media posts, emails, community flyers. And the last thing to keep in mind, once again, I'm obsessed with this idea of reimagining what mental health services can look like. So I wanted to give something that is really low intensity, once in a while, 10 minutes a day, for just 4 weeks, which is very different from, again, the models that we have in traditional face-to-face therapy. And I wanted to know if that was gonna be enough to actually move the needle for people. And in terms of effectiveness, I went with a commercially available intervention. You can go right now to the App Store and you will find this app. It's not designed for people of color. It's not culturally adapted, but it has a very amazing evidence-based components. It has everything that I will do as a clinician if I were to teach people how to use mindfulness to cope with discrimination. The only thing that, once again, it's just this idea of absence of evidence is not evidence of absence. I'm not convinced that this intervention is not going to work. I don't have data to suggest that that's the case. With that in mind is, what was the alternative if I weren't to choose something that is commercially available? Waiting until a culturally adapted version exists, when, keep in mind like the context of when this study happened. I just thought that that wasn't necessary. Once again, I don't think that's the way that we can actually advance equity in this field. Forget this, there's no misspelling here. But also importantly, if we collect data suggesting that this intervention doesn't work, I can see what pieces of the intervention doesn't work, what are the outcomes that actually I'm not able to move, and then use those data to improve the app. In other words, taking a data-driven approach to culturally adapting instead of assuming a theory that needed to be adapted. Okay, so let me tell you a little bit of the findings. So it was an RCT. In the end, we reached almost 240 people. We actually doubled our recruitment goal because within a month, we had already met 50% of our recruitment goal. Within a month, with something that I have never seen in any of my research. I don't think that it will ever happen. I think that that's a cohort effect of the very specific circumstances that were happening in this country, the specific needs. Yeah, I don't think that that will ever be replicated, hopefully, because we don't want to have another 2020. With that in mind, we are reaching still mostly females. We do a terrible job at reaching males in this type of work, and actually that is not just in digital interventions. It also applies to traditional face-to-face therapy. You can see the breakdown in terms of race and ethnicity. So we did a good job capturing people who are Latinx, Asian, not as much Black, multiracial, and Native American. We didn't do a great job. 60% of them didn't have enough money to pay their bills month to month, okay? And in terms of mental health needs, keep in mind that I enroll people based on whether they were exposed to discrimination. Normally, most trials try to enroll people based on whether they meet criteria for anxiety or depression, right? So in other words, you already have participants who have enough room for improvement. That wasn't my approach. My approach was to give these services to people to cope with that, with understanding that maybe this intervention is going to be more or less effective, depending maybe even in terms of like your mental health needs. But you can see that being exposed to discrimination was related with 90% of them having what we will call clinically significant levels of stress, 40%, over 40% clinically significant levels of anxiety, and almost 40% clinically significant levels of depression. So there was some mental health needs, definitely way above like what I show you in terms of prevalence rates in the United States. Does this work? All our efforts or attempts to actually make these interventions more equitable, did that translate into better reach and engagement? I almost killed myself. In terms of inequity in recruitment, there was inequity in recruitment. We screened over 3,000 people, and you see actually the percentage of people who express interest in our intervention. It's pretty well distributed between Latinx, Asian, and Black. Now remember who actually enrolled here. So in other words, there's a big disconnect between, for example, the Black population that express interest and our ability to actually enroll them in treatment. So from the get-go, I already have information showing that I need a better job at actually reaching the Black population. I don't understand specifically the mechanisms yet. Is it like more stress? Is it that actually this intervention doesn't feel relevant to them? But that's now at least an indication that we need to do more research around this area. In terms of, remember, we tried everything that we could think of. We posted flyers in community events and places that actually the population that we were trying to reach navigate on a regular basis, social media, emails. The most successful recruitment strategy was with community partners, what I often call community champions, people who actually vouch for you in the community. send emails to groups. That was the best way to recruit people. 82% of actually emails that our community champions sent. 1% came from physical flyers. 1%. It was a total waste of money and resources. The flyers, I thought that they were beautiful, and they were in color, and they were so expensive, and we got 1% of participants from that, so not super helpful. But something that I feel really, what is the word? Hopeful about is the uptake. All participants in this trial downloaded the app, created a profile, and at least used it once, which contrasts, again, with what I explained before. I'm not surprised because we helped them download the app, install it, and learn how to use it. But once again, I think like sometimes in this field, we make assumptions that if you build it, people will come and they will be able to use it, and that's not the case, and I think that this shows that. Now, in terms of engagement, remember, only 4% of people continue using this app after 2 weeks in general. Not this app, sorry, digital interventions in general. However, in this particular case, people use the intervention for 17 days, from a range of like people never using it to using it every day during the 4 weeks. They completed on average 25 meditations, and they meditated for 250 minutes, range of, again, someone who didn't meditate at all, and 36 hours, something like that. Please help me with the math, but like I think that person probably was levitating by the end of the trial. Importantly, remember that like the way that engagement is described in the literature is like a hockey, what is it called, Jeff? Hockey stick? Hockey stick, there you go. I knew that you were into hockey. The hockey stick, because pretty much it's a steep decrease and it stays flat. In other words, after 2 weeks, engagement goes down and it stays 0. We didn't see that in this trial. It was, I'm not showing you the difference, but it was pretty much equivalent how much they meditated in the first 2 weeks versus the second 2 weeks. And that's something that normally we don't see in the literature. And only 14% of people didn't stay until the end of the trial. So very different from what we normally see in the literature. And this is not super interesting to me, whether this thing works. I kind of already knew that it was gonna work, just based on the literature. There were statistically significant differences among the intervention group and the control group in terms of stress, anxiety, depression, rumination, increases in mindfulness, increases in self-compassion. By the way, in clinical psychology, we know, especially for interventions that we assume that are gonna have small treatment effect sizes. I was expecting to see like a coherence D of 0.2, something like that. When that happens, it is possible that you might have a statistically significant differences, but they might not be clinically meaningful. In other words, it's not really moving the needle in their well-being of people. So I'm not presenting this data, but we calculated the percentage of individuals who met what we call in psychology the minimum clinically important difference, which is a metric of a reduction of symptoms that most people will consider that is impacting their well-being. In terms of stress, 61% of people by the trial have like that MCID, and it was from 41 to 48% for depression. And most of that happened in the first 2 weeks. So even in 2 weeks, for almost 50% of our sample, we are able to achieve a decrease in symptoms that they might consider clinically significant in their lives. Yes, please. Yeah, excellent question. Thank you so much. I completely forgot to talk about that. We wanted it to be an active condition. That's a big limitation in the field. Most of the time, it's a wait list control. We said like treatment as usual. Seek services on your own, or try to find a digital intervention that is commercially available. We have some suggestions. No one accessed any services, so for all intents and purposes, it became a wait list control. Because also for equity reasons, we gave them access to the intervention after a while. So big limitation, that in the end, it wasn't our intention for be a passive control, it became a passive control. I should have known better.
Bias and who gets on the study.
Exactly. Yeah, I think and that's a limitation for sure of this study, and a limitation, I think, in my field in general. Who's actually being rich, who's actually self-selecting to enroll, and who wants there's randomization in place, who's willing to go through randomization. Because I have done other studies in which we don't randomize people. We said, if you sign up, we'll give you some type of intervention. And we tend to enroll more males and more Latino and Black males. So in other words, it seems that those populations might be less willing to wait or being randomized to something that they might not want. So they want something here and now. So definitely, something to keep in mind. So what are some of the takeaways from this study for me? When it comes to reach and adoption, we had a more diverse reach. Again, this is a 100% racially and ethnically minoritized sample, and outstanding uptake. It was 100% racially and ethnically minoritized individuals. We are not great at capturing the Black population, even though actually was like the identity that was depicted the most in our materials and that. I think that something to be said about many of the dynamics of this country and distrust from this community. Most of the engagement happened through community partnerships. If there's one takeaway from my work is truly going out in the community and making these services available in a way that actually fits with the needs of the community is the best way to reach them, instead of assuming that just because you are gonna make it available, they will use it. Again, the uptake in this trial was 100% compared to the 21 to 50% that we see in the real world, so much better. In terms of engagement and the maintenance, it was consistent through 4 weeks, something that, again, it really, you can see like the differences in percentages that we see in previous literature. And with that, I think that I would say that incorporating DEI principles and implementation of these tools work. We were able to plan and execute a trial that from the inception was trying to think about how we can reach these populations better and make small tweaks. If you think about it, this was nothing groundbreaking. Just we were thoughtful about the ways that we would try to reach these individuals. In terms of effectiveness, that I think it's a big concern in the field. This was, again, an off-the-shelf digital intervention, and it was effective for racially and ethnically minoritized individuals, for Latino individuals, for Asian individuals, for multiracial individuals. And the reduction of symptoms in many cases were clinically meaningful. And once again, I think that this goes against some of the common wisdom about the importance of culturally adapted interventions. I'm of the idea that we should take a data-driven approach. Let's implement it out in the community. Let's collect data. If we have indications that actually there are inequities in outcomes, once we identify those inequities in outcomes, like in my case, I know that there's an inequity in recruitment. I'm doing something that actually somehow is not capturing the Black population that they express interest. Now I have a very specific issue that I can solve instead of assuming a priori that I needed to change the entire intervention or my entire recruitment strategy. So once again, I think a big takeaway for me is not making assumptions a priori and collecting data, and based on data, making adaptations if needed, only if needed. And this goes with something I'm obsessed in my career. My career is entirely focused right now in these good enough interventions. Interventions just need to be good enough. What do I mean by that? I often use an analogy to explain this idea of good enough. Copper versus gold as a conductor of electricity. We know gold is a much better conductor of electricity than copper. If that's the case, why do we use copper for most cords, gizmos, and gadgets in our everyday life? Because it's good enough, because it's cheaper, because it's more available, because it's more sustainable. If we apply that analogy to mental health services, why are we obsessed with this idea of using the gold standard treatments, the most intensive ones, when maybe we have interventions that are just good enough and that are more easily implementable in the community, more easily to disseminate, and more easily sustain? So with that in mind, I think that this good enough approach will have significant reach potential. Now we just need to be thoughtful that in the end, we don't create like another category of people that always receive just good enough interventions while the rest receive gold standard treatments. I don't think that it's either or, but we need to be really mindful if we were to take this approach. With that in mind, I don't think that we need more digital interventions. And if you're the digital intervention, yes, please continue and do an amazing job. But I think at this point, I can think of most of the amazing interventions that we know in psychology to work, at least 5 or 6 really good options for every single one of them. I don't think that that's what's going to make a difference in terms of equity. I think it's more thoughtful implementation of these strategies. And with that in mind, this is the way that I apply some of the lessons that I learned from reviewing the literature for all these years into the design of more equitable digital mental health programs. And I just want to thank you for your time. I will be really happy to take questions. It's embarrassing how much time I spend in social media, but if you scan that, we can connect. I would love to connect. If you send me an email, I may or may not reply. Thank you.
That's yours. Thank you so much, Ramos. I want to just go through a couple things to make sure I'm clear, because it's kind of a cool puzzle that you've solved. So
I don't know if I've solved it, though.
well, okay. So let me go through it then. Your take is that pretty much all any solid intervention, digital intervention for mental health, is going to be effective if you sort of like do it and maintain it for the expected amount of time. That pretty much the 10% happier. The reason that this was successful, you call implementation, is two parts. One is like recruiting people into it, and that's where you're designing things to say be a person of color so they feel like it's for them. And then the second part is about maintenance, like actually doing it. So I just looked up the 10% happy. It's a white dude, right? And so
Pretty much all people in that.
all of them are like white dudes. Okay. So the person feels like, okay, this is for me because of the recruitment material. Okay. Just make sure I'm right. And then somebody helps me get onto the app and do all that. And it's a white dude, but like doing something that is shown to be quite powerful. Is it I need to feel like this is for me is just at the sort of like entry point? And then like it doesn't matter what they are, I'm doing it for me after that. Like what is happening there?
Yeah. Excellent question, and something that I think that I did a really poor job at during the presentation is talking about the psychoed piece during the onboarding procedure. Because definitely I think the buy-in, the initial buy-in and getting into is mostly what gets people of color from using these interventions, and being aware of like the recruitment strategies and all that really addresses that. But when it came to aligning the rationale of the evidence-based treatment with the background of our users, we used the onboarding procedure. So we pretty much said, like, Jeff, I know that right now, maybe this app wasn't designed for you. This app it has amazing components, but I'm just curious, what are your impressions to this? Some people were like, that didn't even cross my mind. I'm just really interested in the principles. That's going to be fine. Some people were taken aback. It's like, okay, you designed this program for people of color, and now you're giving me an app with a lot of white dudes.
Yeah.
Right? So with that in mind, we provided Psychoid about like, okay, I completely agree that that app wasn't designed for you, but let me tell you why these principles might be especially helpful for you and how they can disrupt the mechanisms by which discrimination gets under the skin. And that buy-in about aligning the evidence-based components with the expectation of people, I think did a lot of the job for us. I think that explains some of the engagement.
Okay.
Right now we are using this approach of an onboarding procedure, but I don't see a reason why that cannot be automated in the future.
Yeah, I see. So it's basically the tricky thing that you did here was, here's some medicine. The medicine is standard. It wasn't specifically designed for you, but this medicine is going to be really useful for the thing that you're struggling with. You, because of your identity, is struggling with. Okay, that's really clever. And then the other part, so you call it implementation, but there's like recruitment is one piece, which obviously we fail at most of the time. And then keeping people taking the medicine, so to speak, doing the thing. And we also fail there. You seem to be successful on both of them. Is it that sort of like, that sort of educational piece of like, this is standard medicine, but this is why it's so important for you? Does that help with that second piece as well?
Yeah, I think like something compared to other approaches that I have seen, we emphasize that any type of engagement was better than no engagement, and that we recognize that they have a lot of things on their plate. make it your own. We often use a metaphor with them. It was like, think of this intervention as flossing. I don't know anyone who doesn't floss one day and says like, I'm a terrible human being, I will never floss again. Actually, they just try it the next day.
Yeah.
Take that same approach with this medicine. Try to, if you miss a day, nothing happens. Try next week. Do you miss a week? Nothing happens. Just try the next week. That plus, I think if we think about like models of engagement in digital interventions, you need to have opportunity and motivation and all that fun stuff. I think the 3 messages that people were receiving a day was really at least cueing people to, oh, I need to do this. People hated it though. People hated the text messages. The main complaint that we had with intervention was, this was so burdensome, you keep bombarding me with these messages. But I think that now as a field, we need to do a better job at understanding between users' preferences and users' needs. Is it okay that I have participants who are maybe irritated by this, but actually more engaged? Versus giving them something that they think like, oh, I just want one message the time that I personalize, but I ignore it most of the time. I think that's still an empirical question.
Okay, cool. While I ask the next question, I'll open up to the room. If anybody has any questions, we'll get our mic runner out there. Is there anything we can learn then for what you called the ideal samples? So like, is maybe one reason the ideal samples suck so bad is that, okay, it's a white dude on 10% happier. I'm a white dude.
I love white dudes.
Yeah, they can be all right, you know. But they're doing, the ideal samples are doing poorly. They're not really taking it. They're not really staying engaged. Could it also be just because that they share my identity, I still don't understand why this is useful for me? So is there anything we can learn from your REM work that could also apply more generally back to the ideal?
I think I mentioned this during the presentation, that designing for the most vulnerable in mind just benefits everyone. I think some of the same barriers that we see in the literature for majority samples are the same that we are seeing with racially and ethnically minoritized individuals. It's just the degree of that. Like, let's say that you have a lot of responsibilities, things on your plate, but when we see with racially and ethnically minoritized populations is that they have so much compared to other people. So we right now are conducting a study examining the barriers for people to stay engaged with these interventions. We had a diary study. Every week we kept track of things that were getting in the way. We have like the app usage data, so we can map like when do they use it, what are the things that they are reporting. They face the same type of barriers as majority samples, but they face them quite more often than what we see in the literature. So the same lessons can be applied. And actually, I will argue that there's value in including both racial and ethnically minoritized samples and white samples together, even to advance equity. With the big caveat that we don't need to think of the white samples as the norm, or like this is normal, the rest is kind of like deviant, or they are a special population. But if we see that actually some populations are having differential outcomes, we can start like teasing apart what do we need to tweak about these interventions to make them better for everyone.
Yeah, different obstacles for different folks. Great. Okay, is there a question out there? Maybe in the front, Anthony?
You have one of your slides, a sub-bullet around how AI, generative AI, is changing some of these dynamics. Could you speak a little bit more about that and how you plan on incorporating that into your research?
By the way, thank you so much. You are such an amazing nodder. When I was presenting, you were just like this, and I really appreciated that. Regarding the literature about AI, I highlighted that AI-powered tools have better engagement compared to other interventions. And I think it is just the dynamic of how people interact with these tools. You get a response in vivo, and they reinforces the user's behavior. So it's more interactive than some of the other work that we have in the field. For example, like a CBT course, some of the gold standard that we use. People read some material that is pretty dry, to be completely honest with you, and later they have to practice on their own without any type of feedback, and they have to do their homework, right? Versus chatting with this tool that is actually giving me feedback. If I say like, hey, I'm really struggling with this idea of cognitive restructuring, how am I supposed to do it? You get feedback, you get corrective feedback, you get suggestions about how to deal. I think that AI is gonna be, going back to some of your points about how some of the lessons that can be applied, AI, I think, can be used to really motivate people to stay engaged and accountable and all that. At the same time, I think if there's an area of research that makes me feel worried about inequities is AI. I think the samples are just even worse than what you've seen with other types of interventions, and who have access to them and benefit from them is, yeah, we need to do better with that. That's the biggest concern, but I truly think that AI is really gonna facilitate the engagement, maintenance in digital interventions. Going back to automating some of the things that we did through the onboarding procedure, for example.
Could you say a little bit more about that last bit? What is it you're worried about with the AI? Is it that when they're studying AI interventions, their sampling is problematic?
The
or
data
limited?
that is used to be trained.
Training data,
Yeah, the training data, the baked-in assumptions. We have seen some preliminary data that those tools are less empathic with people of color. They sometimes say things that we will consider like microaggressions, and that's when it gets mild. It can also be pretty racist, the model. So unfortunately, some of those societal biases are baked in into the training data, and if we are not aware of that, that can be problematic.
Gotcha. We had a couple of questions from Zoom, but I think we've handled them pretty well. So one was like, if DEI is really important, why do we not need cultural adaptation? But I think it's around the recruitment and the maintenance. The other was when using AI, why is there more retention? And I think you were answering that there. Great. Another question in the room here, and then Bingju maybe.
Thank you. I'm concerned about the follow-up. You made measurements of 4 weeks. I'm worried about 4 years, 4 months. The problems that are the stressors are not going away. And so have you followed these patients longer to see if the gain is persistent or does it dissipate?
Just washes away. Thank you so much. I appreciate that question a lot because I think that's a serious concern. Okay, maybe I was able to move the needle for people in a way that they consider clinically significant, but maybe after week 6, that's completely gone. That doesn't seem to be the case. So now in some of the work that we are doing now, we are following up people at the 3-month follow-up and 6-month follow-up, and some of those gains are maintained. The effect sizes are tiny. So again, this is just a good enough intervention. We are still we are seeing a Cohen D of 0.2, but those gains are maintained. Now, just for the sake of argument, Jessica Schleider, now at Northwestern, her entire program of research is about single session interventions. One thing, just once, for 50 minutes, and she has shown effects that stay a year later for 50 minutes. So this is even way more intensive than, for example, what Jessica Schleider is doing with single session interventions. So once again, I think for me, that's just some of the data that invites me to re-envision what mental health services can look like.
Great. Bingju.
Thank you so much for the talk. It's really amazing. So I have a question about regarding the potential in AI, or why people don't stick to some of the social media applications of implementing mental health treatment. I feel like part of the reason is because before the age of AI and the age of social media, people don't stick to those applications usage for a long time. It's not a new problem. But I feel maybe that's the reason. It's not because of motivation or other stuff. Maybe it's because the treatment itself is not deep enough. We do a lot of task-based treatment assignment, like CBT and DBT, that will assign people to, okay, try to do this in a routine time, and you come back and you do this again, and we want to change how you think cognitively. But I feel like the potential in AI is because AI's treatment is more this is more conversational based, or more narrative, more psychodynamic, psychoanalysis, and that is the thing that intrigues people because it's more in depth, and it's very reflective of their own personal kind of autobiographical narratives experiences. So I do want to I wonder your opinions on this, because that's the potential of AI, but that's also the risk of AI, because people are it's not evidence-based treatments, it's just psychoanalysis to some extent. So what do you think about this?
Yeah, so something that I would like to clarify regarding the deep versus superficial versus deep is that I will argue that when you compare really good psychodynamic therapy, by the way, I've been trained as a clinician from a psychodynamic perspective. I also know CBT, I also know DBT, so I have used all those approaches and I love them all. I don't think that it's a fair characterization of CBT and DBT as superficial versus psychodynamic as really deep. I think from any approach, you can have really meaningful conversations about your issues and engage in a very deep way. I don't think that is the protocol itself. But going back to the AI aspect, it's just interactive component that I think that like the tools that we currently have are missing. Now with AI, regardless if they use a CBT model or a psychodynamic model, I think it's gonna be more engaging. The last thing that I will push a little bit against is this idea that psychodynamic is not evidence-based. Psychodynamic therapy is actually evidence-based and obtains effects just as similar as CBT, but it's more about the data that we are gonna use to train those modalities. I'm thinking like some of the most convincing work that I've seen in the literature is from, oh my God, of course now I'm going blank with his name, Jacobson in Dartmouth College. Oh my God, and he's my friend. This is so sad. But anyway, the thing is, Nick.
Okay, all
Yeah, okay. Whew. Nick Jacobson, he actually tried to train his model using data from the internet, and it was terrible. So what he ended up doing is actually using data from therapists and experts and using that data to train the models. And the effect sizes that he have found is completely self-guided, CBT-based. Effect sizes that we often see just in face-to-face, once a week, 15 minutes. So in other words, it's just about the data that we use to make these tools effective, but whether it's psychodynamic or whether it's CBT, it's gonna work. Let's just use the right data to train those models. Thank you for the question.
Great. Thank you, Bingju, and thank you, Ramos, once again, not only for joining us here, but for all the really important work that you do, and really appreciate all the care that you bring to the research and also the communities that you are trying to help. So please join me in thanking Ramos for his talk today.
Thank you for having me.
This is the last seminar for the winter for us, but we have a really exciting lineup for the spring term. And you can see here, Ben's put up our slides, and we'll be coming back on April 7th, so a nice long spring break from the seminar with Robbie Torney. So please join us then, and otherwise have a great March. Thanks, everyone.